Good afternoon, everyone. 12:30 on a Thursday afternoon. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. Today, we're happy to invite Dr. Sam Bott back to talk to us about pitfalls in rhinology, part 2 of his talk that he gave a couple of weeks back. Sam, if you can go to the next slide. We want to tease the upcoming Lunch and Learns. And we have a full slate through October and November. In fact, we're quite happy that we are almost fully booked throughout the whole year. If there is a talk you'd like to hear, a specialist who you think would give us a good talk, please feel free to reach out to myself and we'll try to get them on the slate. As you know, all our talks are archived up on our website as well as on YouTube by just searching Newton-Wellesley Medical Group Lunch and Learn. Given the times now and how busy our emergency department is, I want to keep reminding our primary care and our ambulatory care about our orthopedic walk-in. Next slide, Sam. And that is open 7 days a week, Monday through Friday, 8 a.m. to 8 p.m. It is a walk-in center, so no appointment is needed, although one can be made. It is also an urgent care, so no ER visit copays. There is a casting right on site, x-rays, trip and falls, twisted knees on the soccer field after school. Please feel free to come on down. We'll are staffed by orthopedic physician assistants and board-certified orthopedic surgeons from the medical group and Mass General Brigham Sports Medicine. So please give that a try and check that out for your patients. Next slide. And then we've talked about the thyroid biopsy clinic, and that's a multidisciplinary clinic, and that can be reached through our Epic referral system. And I will yield the table to Dr. Bott. Go ahead, Sam.
Well, hi, everyone. A couple of weeks ago, we discussed, can everyone hear me all right, I hope? John, is that good?
It's okay. Sounds okay, Sam. Yeah.
Okay. So a couple of weeks ago, we discussed pitfalls in otology, and today we're going to pivot to rhinology and focusing primarily on sinusitis just in time for the upcoming cold and sinus season. Also, if we have time at the end, I'd like to move on to discussing some pointers on COVID-associated anosmia, which we're all encountering lately. So just a reminder of who the members are of our ENT team here at Newton-Wellesley. We all see patients here at our offices, both in the Green Building and also on Walnut Street in Wellesley, and are always available and happy to take your phone calls or emails or Epic questions that you may have. So today we're going to focus on the common conditions of rhinitis and sinusitis. What's rhinitis? What's sinusitis? What's the difference? How do we tell one from the other? And why does it matter? Also, we'll discuss why we want to avoid overtreating or undertreating sinusitis. And finally, knowing the red flags that might indicate a more serious condition that's masquerading as sinusitis. So what's rhinitis? Well, it's in the name, of course. Rhinitis is inflammation of the nose. The nasal mucosa becomes inflamed. The most common examples are colds and allergies, and here's a diagram that I use to explain things to patients. On the right side, we see the normal nasal septum and turbinates, and on the left, we see rhinitis. The mucosa of the nasal cavity is edematous, narrowing the nasal airway. This makes the patient feel nasal congestion or blockage. The inflamed mucosa also produces more mucus, so the patient feels a runny nose, often with sneeze and itch. Rhinitis comes in different forms. Acute rhinitis is a fancy name for a cold caused by a virus, of course, and gives the symptoms that we all know. One important point, though, is that acute or viral rhinitis lasts less than 7 to 10 days. Conversely, anything lasting more than 10 days is not just a cold. Allergic rhinitis is the same idea, but it's caused by allergens instead of a virus. Because those allergens can be seasonal, like pollen, or it can be something year-round, like dust or pet exposure. Because the allergens trigger histamine release, in allergic rhinitis, there's usually itch. Unlike in a cold, and antihistamines and steroid therapy can be more helpful. So what's sinusitis? Well, actually, it's called rhinosinusitis because it's inflammation of the mucosa of the nasal cavities and the sinuses. So back to our diagram, on the right, we see normal sinuses. These are large chambers that connect to the nasal cavity through small openings called ostia that allows air in and mucus out. We also see that the sinus chambers have a respiratory lining that is normally very paper thin. On the left side, we see sinusitis. And in this condition, we see that the mucosa becomes edematous. And that edematous mucosa then blocks the ostia. So air can't get in and mucus can't get out, leading to problems. Over months to years, that swelling can become worse and can lead to recurrent sinus attacks. Sinusitis also comes in different forms. Oops, is that the right one? There we go. Sinusitis also comes in different forms. Acute sinusitis is usually a bacterial infection that starts with a cold or allergy. However, in sinusitis, the swelling includes the sinus openings. So air can't flow in and mucus can't flow out, and this leads to a bacterial superinfection, as we see in this picture down here. The body responds to those bacteria by producing pus in the sinus, and because it can't get out very easily, it's under pressure, and the patient may feel facial pressure or facial pain. Eventually, it does flow out, producing that thick discharge that's typically purulent. And there are also associated symptoms that are most commonly fatigue and cough. Also important, in sinusitis, symptoms last longer than 10 days, as I've said. Because it's often bacterial, we typically use antibiotics, and the drugs of choice for milder cases are, as listed here, amoxicillin, doxycycline, cephalosporins, and quinolones. A couple of points on antibiotic treatment. Notice what's not on the list: Zithromax. I know it's convenient, but it's not really very effective for sinusitis. Also, personally, I avoid quinolones because of the risk of Achilles tear, which remarkably lasts for 90 days after a single course of therapy, and that risk is higher if prednisone is given, which we sometimes do in more severe sinus infections. Over time, patients develop chronic swelling of the sinus ostia, which then makes them a setup for more recurrent infections. So every little cold or allergy can lead to more swelling here that obstructs it. And as the patients will tell you, every time I get a cold, it turns into a sinus infection. For these patients, we use stronger and longer antibiotics such as Augmentin, and sometimes pair that with prednisone if it's bad enough. And if they continue to have recurrent problems, then we even discuss sinus surgery. The idea behind sinus surgery is very simple. Using an endoscope, we enlarge the compromised or obstructed sinus ostium so it can't close down, thereby decoupling the colds and allergies from the sinus infection. This way, colds and allergies are just that, and they don't progress to sinusitis. So what's chronic sinusitis? Well, in chronic sinusitis, the cause is not infectious. It's inflammatory. The sinus lining becomes chronically inflamed, as we see here on the left side. That inflamed tissue then fills the sinuses and produces more mucus. That inflamed tissue also can lead to polypoid-shaped outpouchings, sinus polyps, that then eventually can tumble out of the sinus ostia down into the nasal cavity, causing the nasal polyps that obstruct airflow. So these patients will typically say they have congestion, they have mucoid discharge, and because this same swollen mucosa sits over the olfactory cleft, these patients also will typically say they have a poor sense of smell. Treatment in these cases is to reduce the inflammation, typically with steroids given either orally or topically. For patients with polyps and severe blockage, surgery can be done, and essentially what that does is clear the polyps within the nasal passage, but also remove these tissues here to open up the sinuses so that topical steroid therapy now reaches the target, which is the inflamed mucosa, to keep that inflammation under control. So what's rhinitis or sinusitis, and why does it even matter? Well, there are several reasons. First of all, of course, we don't want to treat colds and allergies with antibiotics because of resistance issues, cost, and side effects, but also because patients with colds who are given antibiotics, they'll get better in 7 days, but they will mistakenly attribute that improvement to the antibiotics instead of the natural history, and they'll ask for antibiotics again next time. And they'll end up being on much more medication and sometimes even request surgery that they don't need. What happens in the reverse case? If we think sinusitis is just rhinitis and we don't treat it, the main problem there is needless misery. Patients feel they're constantly sick with a cold that never ends. They're dragging, they have fatigue, they cough, and they just feel lousy and they need our help, in that case with antibiotics. So how do we make the right call? Is it rhinitis needing minimal treatment or sinusitis needing more treatment? The problem in rhinology is that the nose, and especially the sinuses, is pretty much a black box. Unlike the ear or the throat, we really can't see very far back in the nasal passage. One can't see in the sinuses at all. So we need to make our decision by history. And there are two steps to consider. Step one is duration. This allows us to differentiate all these conditions listed here in a simple way. If it's just a cold, it's going to get better within 7 to 10 days. If it's ongoing beyond that, it's either allergic rhinitis or sinusitis. So if symptoms have gone on for less than 10 days, certainly less than 7 days, it's not sinusitis and doesn't need antibiotics. Now, it might turn into sinusitis, but it isn't one yet. There is one exception to this. Patients with very frequent recurrent acute sinusitis, they may develop a sinus infection within just a few days. But again, that's the exception. Acute sinusitis, duration is longer, so it lasts over 7 to 10 days, as we see, in this diagram. And then allergic rhinitis is either seasonal or year-round. And finally, chronic sinusitis is inflammation and polyps, so it's continuous. So step two in differentiating rhinitis from sinusitis is based on the symptoms, or as I think about it, to sneeze or not to sneeze. Colds and allergies have frequent sneezing. Sinusitis has some sneezing, but it's generally less frequent. Allergies have itch. Think of histamine release. Colds and allergies have mostly clear discharge, although at times it can be green or thick, especially in the morning, but the rest of the day it's mostly going to be clear. By contrast, acute sinusitis, because it's a bacterial infection with pus, is going to have opaque discharge, especially that may look purulent. I will mention that occasionally patients will not describe this purulent discharge because it all goes postnasally. And in those cases, what they will find is that it's typically foul or metallic in character. Finally, acute sinusitis often has other symptoms. The patient may not volunteer these, but if you ask, they'll tell you. Fatigue, headache, cough, and flare-up of any underlying asthma that you won't typically see with colds and allergies. So how do we know whether it's sinusitis and so we've talked about how to differentiate those two. How do we know when it's something that looks like sinusitis, but it isn't? So here's a list of conditions that can masquerade as sinusitis, ranging from mild to severe. We have dental infections, trigeminal neuralgia, migraine, atypical facial pain, and giant cell arteritis. Also, we have neoplasms, the most common sinonasal neoplasms being inverted papilloma, lymphoma, and squamous cell carcinoma. And I'll tell you that on a routine basis, I'll see patients in my office who have these conditions, but who believe that their problem is really sinusitis. The reason that the patient or we may think at first that they have sinusitis is because all these conditions have facial pressure or pain. However, none of these conditions has nasal symptoms. They don't have congestion. They don't have discharge. Patients with sinusitis are almost always going to have nasal discharge or congestion, especially if you ask them about it. So if your patient has facial pressure or pain, but doesn't have nasal symptoms, it's probably not sinusitis, and you should consider another diagnosis.
Oh, good.
So what about neoplasms? These can be tricky because they do have nasal symptoms, like sinusitis. These patients have nasal obstruction, they may have discharge, and they may have pain. So how do we tell the difference? So I suggest considering 3 factors. Sinusitis tends to be bilateral, while neoplasms are more often unilateral. Now that is a soft sign. There are exceptions, but it's at least a start. Second, sinusitis responds to appropriate therapy. Antibiotics if it's infectious, prednisone if it's inflammatory, and neoplasms don't. Finally, neoplasms will eventually develop other symptoms not found in sinusitis, such as neurologic signs or bleeding. But as I say, it can be a difficult call. So if the patient is not responding to therapy as you expect, consider another diagnosis and investigate further. So takeaways from today's talk. It's important to differentiate rhinitis from sinusitis to provide appropriate treatment. You can differentiate the two based on symptoms and duration. Rhinitis is mild and short-lived, sinusitis is ongoing, usually with purulent discharge, fatigue, cough, and often facial pressure. Careful antibiotic selection in sinusitis is important. Personally, I avoid zithromax and quinolones. There are other conditions that look like sinusitis but aren't. Some look like sinusitis primarily because of the facial pressure or pain, but they don't have nasal symptoms. That should give you pause. Finally, sinonasal neoplasms are not common, but when they happen, they look like sinusitis. So if a patient has neurologic symptoms or bleeding or is not responding to your usual treatments, consider further evaluation. So thanks for all of us at Mass Eye near Newton-Wellesley. John and I had talked about this a bit. Rather than take questions now, I think what we'll do is go on to a single slide I've put together on COVID-related anosmia, and then take questions at the end on both subjects. So our bonus talk on COVID-associated anosmia. Some of you may know, maybe all of you know, that even before COVID, we all knew in otolaryngology about this entity called virally induced anosmia. This is essentially like Bell's palsy, but of the nose. So patients would describe that they will get a cold, they'll get all stuffy, their sense of smell will be poor or diminished, but then the cold goes away and their sense of smell does not come back. In most of those cases, the sense of smell gradually recovers over the course of months, up to as long as 2 years, often will recover completely or sometimes partially. It's a rare patient that would not recover anything. In COVID-induced anosmia, again, it is a coronavirus, so it's a cold virus, but there are some differences. One is the loss of smell is usually abrupt in onset. It can be total or partial. The other funny thing about COVID-induced anosmia is a lot of the patients don't have other nasal symptoms. They may have other symptoms of COVID or no symptoms at all. They'll just say, all of a sudden, I lost my sense of smell. When looked at prospectively, this is present in 40 to 60% of patients diagnosed with COVID-19. And in hospitalized patients, it's nearly uniform, 98%. The mechanism is that we know that COVID-19 attacks the ACE2 receptor, and olfactory cells are loaded with these. So we think that that may be the method of entry. In terms of recovery, results vary widely. Recovery can occur gradually, as a typical virus-induced anosmia does, or it can be abrupt. It can be total, it can be partial, or sadly, it can be not at all. Treatment for this consists of what's called olfactory retraining. And I have to be honest with you, I don't know why this works, but study after study shows that it is effective, not only for COVID-induced anosmia, but also the standard form. In olfactory retraining, what's done is the patient takes a set of 4 strong smells. For example, essential oils, rose, lemon, clove are typical examples, eucalyptus. Get 4 smells and smell each one for 15 seconds, twice a day, every day for 90 days. Then rotate to a different set of 4 smells for 90 days, and then rotate to a third set of 4 smells for 90 days. So I'm told that you can get these essential oils at sort of health food stores. The outcome overall for COVID-induced anosmia is 96% recovery by 8 months. That's listed on UpToDate. So that's certainly encouraging. What I can't tell you, because things are still early and we don't have that much data, is what percentage is with olfactory retraining compared to nothing. But we do know that when olfactory retraining is looked at prospectively, it is helpful. So what I was going to suggest is we do have a flyer that we have on olfactory retraining that we give to patients. You're welcome to send me an email through Partners Outlook. I'm listed, and I'm happy. I will send you a copy of it, or alternatively, if John or Audrey would like me to send them a copy that can be distributed, or we can post it in some way. So that's all great. I had for today, and happy to take any questions, John.
Thanks, Sam. That's great. Appreciate that about the, why don't you send me along that flyer in case anyone wants to sure. Either send it to me or Holly or Audrey, we can get that out to them. There is a question in the chat room from Jeff Phillips, who is thanking you for the talk and also asking, what's your favorite nasal steroid? So I know you're not supposed to play favorites as a parent, but
No,
which
but
one's your favorite?
I'm like that hair club for men, guys. You know, I'm not only a prescriber, I'm a user. I like Nasacort. I actually have chronic sinus issues and I use it every day. So my take on nasal steroids is essentially this. I think of it as either Flonase or Nasacort. They're easily available over the counter. They're comparably priced. Everyone loves Flonase because they've heard of it. It's on TV. The disadvantages to Flonase is if you've ever used it, it stings some and it does have a smell that a lot of patients don't like. So Nasacort has neither one of those. It's also less drying than Flonase. And so, especially for patients who say they got nosebleeds with it or whatever, I'll say go to Nasacort. It can be quite expensive for patients who use it chronically over the counter, say from CVS. You can buy it from Costco, even through Amazon. You can buy the Costco brand, and it's relatively inexpensive that way.
And you can get up to twice a day on the Nasacort like Flonase at maximum dose?
Yeah, so that's interesting. You know, one of our things was to increase the dose to 2 sprays each nostril once a day. So it turns out it's equally efficacious whether you use 1 spray in each nostril, BID, or 2 sprays once a day. It's just easier for patients to do 2 sprays once a day. Studies show that if you use 2 sprays each nostril once a day for a month, you can then reduce the dose to 1 spray each side once a day, and it is supposedly just as effective. I have to tell you, I'm still using the two sprays each day.
Thanks. I guess there's not another question. I had a question. I wondered if you wanted to comment about. So we see a lot of patients who, quote unquote, have this non-allergic rhinitis. And what's your kind of treatment algorithm when these patients come in, you know, around food or around other reasons that they have this rhinitis that steroids just don't respond to?
Yeah, well, you know, no offense to the allergist, but I do think that some of what we call non-allergic rhinitis is just that it's allergic rhinitis, but we can't identify the allergen. Patients will often say whenever they travel to this place or they're exposed to this place, they sneeze their head off. And I just have to believe that that's allergic based. And so in addition to the steroid sprays for those patients, I'll add an antihistamine, either oral, like Claritin in the morning, or Zyrtec at nighttime. And you know, if some patients will prefer the spray, we'll put them on azolastine if they have a runny nose, and that's helpful. One thing I'm just going to mention, if there are no other questions, is I also, whenever I put a patient on nasal spray, I tell them how to do it, and that's important because otherwise they'll spray their septum and they'll end up with nosebleeds. So I tell them the easiest way for them to do this is what we call cross-handed technique. So I have them shake the bottle, take the bottle with their right hand to spray their left side and their left hand to spray their right side. By doing this, they aim the spray laterally instead of hitting their septum. So they're less likely to have nosebleed issues.
That's a great pearl. Thanks, Sam, for that. Another question about, is it better to use the nasal steroids at night or is there no difference?
Well, studies say there's no difference. I think I sort of leave it up to the patient. If they have a lot of daytime allergy symptoms, in their work or their home, then I may have them use it in the morning. When they ask me what time of day is best, I say the time of day that's best is the time of day it's easiest for you to remember, because compliance can be an issue with this. So, you know, a lot of patients will use it in the morning first thing because it's easy for them to remember. Otherwise, I don't have a strong preference. If they have a lot of dust allergies or the dog is getting in the bed and so therefore they have problems at night, then nighttime would be better.
And then another question here about how do you counsel your patients about the long-term effects of the chronic nasal steroids?
Yeah,
Lots of talk about glaucoma, cataracts, excuse me, et cetera. Yeah.
Yes. So I recently looked at the studies on this, and there are some studies showing that with long-term use of intranasal steroids, there is a chance for glaucoma, but if it's there, it is quite small. First off, at least a quarter, maybe a third of the patients that I have on intranasal steroids are on oral steroid inhalers for their asthma. And the amount of systemic absorption from the nasal spray compared to the asthma spray is negligible. So I tell them really the risk in your case is from the asthma and the asthma inhaler. And yeah, there is some risk from that. For regular old Nasacort spray, I think the chance is so low that I don't do anything. I don't tell them anything other than possibly accelerated cataract risk. That's really for patients where we're talking about them using it for decades. If a patient has significant glaucoma, then I may mention it to them and say, we're putting you on this spray for 6 months or forever, If your glaucoma is, your pressures are going up, then let's talk.
Okay. And how low do you go down on age? I know you see pediatrics and those of us who are family docs and pediatricians on the call. How low do you feel safe using these medicines?
Yeah, so an interesting question. I'll often put my pediatric patients, for example, if they have turbinate edema, allergies, and so on, I may put them on an intranasal steroid spray at a lower dose, one spray each nostril once a day, down to about age 3 or age 2.5. The thing about intranasal steroids is I don't consider them a good chronic therapy for children. So I mostly use those sprays diagnostically. If we're trying to figure out, okay, is their problem allergic? Should they go off to the allergist? Is controlling inflammation really going to help them? But otherwise, I'm disinclined from putting a child on chronic intranasal steroids. I generally won't, even my 20-year-olds don't want to use it on a daily basis.
Sure, and that goes to Dr. McNagny has a question. Any reason to kind of like skip a couple months if you can get away with it on the Flonase? Are there any data regarding the eye kind of long-term side effects?
Yeah, I mean, there are plenty of studies, Sally, showing that chronic intranasal steroid sprays do not have any significant effect other than possibly mildly accelerating cataract formation. If you look hard, you can find some studies regarding glaucoma. I don't know about washout. My patients tend to fall into 2 groups, those that get recurrent sinus infections at a certain time of the year. And I say, okay, I want you to use your steroid sprays from Thanksgiving to end of March, or if it's allergic, I'll say, I want you to use it during your allergy season. And then on my second group, which are my chronic sinusitis polyp patients, and if I don't control their nasal symptoms with things like Flonase, they're going to end up on a prednisone bolus. And the way I see it, that's much worse for them than the Nasacort.
Sure. And then there's another question here. Before I get to the last question, I just want to make sure folks know 2 other educational opportunities that are coming up. Next Tuesday is APP Grand Rounds, which are in person at the hospital and also live stream. We have Megan Grady talking about AFib and AFlutter. So that's at 12 o'clock. We're excited about that talk. And of course, every Wednesday morning at 8:30 is Medical Grand Rounds. We have a nephrology talk on coming up next week. I'm not quite sure of the title yet. Lucy Panisian had a question about nasal saline. Any favorites, tips, or tricks about nasal saline for your patients? There's so many of those out there at this point.
Yeah, thanks, Lucy. There's 2 issues with saline. First, yes, we definitely have people who have dry nose, especially in New England. And so something as simple as using nasal saline spray can be very helpful for those patients if they describe dryness, if they describe a lot of postnasal drip. Then just 2 squirts of over-the-counter saline spray once or twice a day. I say whenever your heating system is running at that time of the year is very helpful. The second is nasal irrigations, which are not as daunting. I don't know if you've never tried them, I can tell you they're not as daunting as they sound. I do tell patients, so these are the Neomed Sinus Rinse, Neti-Pot. I prefer the Neomed Sinus Rinse. And I just tell them, you get it in any drugstore, mix it up. I say the first time you used it, it feels like you jumped in a swimming pool and all the water went up your nose. But after you've used it for a few times, you may very well like it quite a bit. It rinses out the nose. It really does demonstrably get rid of allergens. There are a lot of patients who just absolutely love this stuff, and there's certainly no downside to it. So for patients who have, again, kind of chronic discharge, postnasal drip, something, it's certainly very easy to try.
Excellent, Sam. We'll have to leave it there. We will invite you back because these talks have been amazing. Thanks again for your time. And, let's go Red Sox. Got a playoff game coming up. So see if we can move on to the next series before next talk.
Great.
Thanks, Sam. See you later.
John.
Yeah, bye.